is a project I've been involved in for a few years now. We've called it Strengthening a Palliative Approach in Long-Term Care, or SPA long-term care. The first term we used was SPAC, and Paula Neves, who was one of our key partners, completely kabushed that and thought it sounded too much like spank. So SPA sounds good, sounds relaxing, so that's kind of what we're calling ourselves. Funded by, we have partners with Extended Care, McGill, McMaster, where I'm from, and Shalom Village, as those are, and then TVN is the main funder, as well as some funds from CIHR. So I have lots of slides, so I'm not going to be able to talk to all of them. But as you can see, we have a huge co-investigator team, people from all over the world, and really, really good people to work with, all interested in improving palliative care and long-term care homes. We have an advisory board of, I think we're close to 30 members now, and some of them actually that have been presenting. I saw their names on the schedule over the 2 days. Hugely important in this program, and we use them a lot as we develop our interventions. So just to give you a bit of a background, as you all know, the population is aging, and we're seeing more and more people die in long-term care. And I think the length of stay right now is about 18 months on average. So they are coming in very frail, lots of comorbid conditions, very complicated to deal with, and most of them have dementia. About 70 to 80% have dementia. So a very complicated, very vulnerable group of people that we're working with. This is the model that's been around for a while. It's different than a cancer trajectory where it starts at the top and has a straight line and goes down. This is kind of the trajectory we use for people with complex multiple conditions, because they have little bursts of improvements, decline, which makes it super tricky to plan care and to figure out when we should be working on end-of-life issues. So it's a very challenging population to work with. The challenge that has been happening is that we're always waiting for that question mark to be answered. So when is it we're supposed to be implementing end-of-life care guidelines, planning for appropriate symptom management and those kinds of things. So the new philosophy, which I was glad to hear the previous presenter was speaking to as well, it's really looking at a palliative approach. So we're actually recommending that it starts even before people come to long-term care. So in the primary care office, in the community, I'm actually getting my teenagers to start to talk about what's important to them and to get them more comfortable talking about issues of death and dying. They don't like it very much, but we're still doing it. I try not to do it over dinner because we like to have fun at dinner, but anyway, so I think it's, we need to break through the stigma, and everyone's afraid to talk about dying. Our initial studies said that staff are afraid to talk to family members. They don't want to upset the family members. Family members are afraid to talk to residents because they don't want to upset the residents. But when you ask the residents, generally they're actually okay with talking about it. So I think we're all just so afraid of upsetting one another that none of these conversations are happening. So a palliative approach really begins at admission or before, if we're lucky, based on symptom management. So if they're having pain, whether they're considered end of life or not, we should be treating it. Not so much emphasis on prognosis, because we know they're only going to have a few years left, most likely. Some may have more. But it shouldn't dictate our interventions. And definitely an interdisciplinary approach. The whole gamut of people in long-term care need to be involved, given most of residents' needs are very holistic. Needs to have a focus on preparation and care planning, talking about goals of care with residents and families beforehand, and certainly a need for lots of family education and support along the way. So this is a 2-year study. We're just wrapping up. We have another 6 months. And we're also, so we have 4 homes in Ontario. We're also rolling it out in 4 homes in 3 other provinces. And we're just looking at kind of the next level of the study as well. So It's really a cool way to do a study. We use participatory action research. So for those of you who have heard of randomized controlled trials where it just sounds icky, we have to control everything and have to time interventions at a certain time. This is really kind of fun. So you can engage with homes, probably things that you do anyways. You see a need, you react to the need, you develop an intervention, and you share it and you evaluate it. So we're able to do that, and it's, I think, probably one of the best approaches to use to really make sustainable change in practice. So we have a champion team, we have the advisory board, like I mentioned, and then these programs that we came in wanting to do, they shift. So if we're finding homes aren't able to do certain parts of it, then we figure out what can they do and how do we work with the homes to make it work. It's a mixed method study. We're using focus groups, so asking residents, family members, staff, pretty much everybody we can find to get their feedback. We do have a couple of surveys, some chart data that I'll mention, and as I said before, we have 4 long-term care homes, 2 in Hamilton and 2 in Toronto. So this is kind of what we call the SPA core components. The first stage is developing a champion team, and we know from the literature and our experiences, not even related to palliative care, but if we want to make a change in practice, we need a hub of people or a champion team to help make that happen. So that was one of the first things we did with our 4 homes. Then we moved on and we gave some education to the champion team, got them caught up to speed, and then we looked at kind of educating the masses in the long-term care homes. And we did it very informally. We're still holding these monthly comfort care rounds, and we leverage the palliative consultants that currently work in the community to come in and help staff run these. So it's really a chance for them to debrief previous residents' deaths, things that have gone well, not gone so well, ways that they could have improved it. And eventually we're looking at kind of building them so that we're talking more about current cases. And if staff have questions about care, we have the palliative consultant or the champion team member to help answer those questions. The palliative performance scale. How many people have seen the palliative performance scale? It's a pretty popular one. Mixed feelings about using it in long-term care because it was originally developed for people with cancer who lived in the community. But unfortunately, it's really all we had to choose from. And there was some initial work done in long-term care to say that it was pretty helpful and did help predict mortality. So we've kind of adapted it in our study, and we're looking at actually using more of the MDS-RI data to help trigger care planning instead. But for now, this is great because PSWs can use it. It's very quick and easy. Once we get the initial training done, people don't even need to look at the scale. They can come up with, oh yeah, that resident, it was 40%, but now they've gone down to 30%. So it's a way to help communicate among staff. And what we use the palliative performance scale for, and this has been done with a group in London, so a score of 30% or lower, it triggers a family care conference. So this is where it's really more end of life, and we're trying to bump it up to 40% because we're finding we're not always hitting people in time. They pass away before we can actually do this. But it's a way to bring families and staff together to talk about goals of care and help prepare families and residents, if they're able to, with some of these end-of-life things that may come up. And this is a video, actually. If you ever have a chance and if you're interested, you can Google it on YouTube. It's called All on the Same Page. And my colleague Deb Parker from Australia, who helped us develop this program, they developed this video for their education. She rolled out her program across all of the homes in Australia, and this was a key tool that she used to educate them. I love it because it has the Australian accent, which just sounds so nice. And really, it's a nice way to show staff and families just what it means to have a family care conference. Yeah, I think I've covered that. So some of the outcomes that we're hoping to see with our intervention. We want to see happier residents and families satisfied with care. So we did do a baseline survey, and we'll be doing that after as well. Really, one of the things we're honing in on now is trying to get staff more comfortable with having conversations about end of life. So I'm actually taking those cards with me. I don't know where I'm going to take them back, and I'll be emailing you because I think this is a great tool and fun, so people don't really feel the pressure of having some of these discussions and decisions. So anything like that I think is great to kind of help staff feel more comfortable with talking about end of life. And ultimately, we would like to see decreased hospital transfers, hospital deaths. We want to see more people dying in the long-term care homes. So what we did, I'm just going to quickly talk about our focus groups that we did initially. We really wanted to get a sense of what are current practices, what do staff, family, residents think about this intervention and about palliative care practices in general. And we really wanted to engage as many people as we can. So we kind of had a two-pronged purpose. We wanted to collect data, but we also wanted to meet staff and kind of get their buy-in into this program early. So we ended up with about 21 focus groups across the 4 homes, good representation from residents and families and staff. We had 77 support staff, PSWs, licensed nurses. We had management, pretty much we had dietary, rec therapists, pretty much everyone we could find, even maintenance. And I think we had some admin support people in there as well, and a few volunteers. So main findings, really people thought that palliative care is comfort care at end of life. So people who are actually dying, that's when they thought palliative care should be happening. Lots and lots of dialogue. Probably every focus group talked about what's the difference between palliative care and end of life care. I'm sure you hear that as well in your homes. It's always the first thing that comes up. And I just feel like saying it doesn't matter because it shouldn't change how we see people. Really, it's about good quality care. So whether they're, have 5 years left to live, 6 months, we still are thinking about the same things and still want to talk about goals of care. It's very personal. One of the main themes in the focus groups, staff, residents, and families want to make sure the person who's dying doesn't die alone. And they talked about different ways that they tried to make that not happen. And we really actually had some really interesting data from residents. And it was something we never expected to hear, but spoke to their lack of empowerment and really feeling like they had no choice in some of these decisions. So essentially we had someone come right out and say, it wasn't my decision to come here. Why are you asking me now about this stuff? So they're feeling, they haven't really been involved in care decisions, and all of a sudden now we want to find out about what are their wishes and goals for care. So that was kind of an interesting concept. We had some very vocal residents in our groups. And the whole notion of honoring death, the old traditional way of having people come into the long-term care home through the front door, leave through the back door. Now we're having them leave through the front door as well, and it's a bit of a ceremony. We did a staff survey, had a fairly good representation across groups. Main finding really is support staff. That was the other thing I noticed in the last presentation. Definitely had less comfort with providing palliative care, felt less involved in palliative care discussions, less resources available to them to help them have these conversations and support families and residents, and yet spent just as much time with residents and families. So this is one of the things I think we really need to think about, even though someone is, even having someone drop in a tray, some of these conversations happen at that point, and staff need to be prepared and comfortable to have these conversations. This is the other, so we also did a chart audit. So We did this actually thinking we just wanted to look at what our baseline data look like, but it ended up turning into kind of more of a knowledge dissemination activity. So you can see on the right-hand column, we averaged rates across all 4 homes. So we looked at deaths in the hospital, at the long-term care home. We looked at ER visits in the last year of life, month of life, week of life, and then planned ER visits and unplanned ER visits. And so these are kind of our averages, which interestingly line up almost perfectly with the national averages as well. And the other piece to this, we added each specific home's data as well. So we had another column in here with the homes, how many people died in the hospital. And then we took that back to the home and we had them reflect on their finding compared to the average findings and asked them to think about, why do they think their hospital death rate is a little bit higher than what the average is. What are some of the reasons they think that might be happening? What are some of the barriers? And then strategize ways to help bring their average more in line with the averages that we're seeing. So it was kind of a neat opportunity. Learn lots of things, again, that we never expected to learn. The importance of advanced practice nurses in staff development came through, importance of nurse-physician communication and strategies at some of these higher homes or more highly functional homes were telling us they were doing that helped us understand why their rates were a little bit better than the other homes. So we have, if anyone's interested, we have these family care conference forums. We worked with Judith Wall, who's a lawyer in Ontario, so we wanted to make sure they're legal. They're a little cumbersome. I think she probably added way more text than we were hoping to have in. But we are using those, and they're helpful to use with the video. The other thing is we developed some pamphlets. We're calling them illness trajectory pamphlets. And this was really in response to some of the families' angst, I guess, with a palliative approach. And this is kind of a way we thought we could give them a pamphlet. They could read it when they're ready to read it. There's some good resources there that they can link to and some questions that they may want to consider to ask their family member. So we have one for dementia, frailty, heart failure, kidney disease, and lung disease. Happy to share these. We're really getting a lot of positive feedback from them. And we're doing some evaluation as well. So really trying to empower families, residents, and providing a nice way for them to learn about a palliative approach so it's not too scary. And lastly, I wanted to talk about the dignity blanket, which one of our homes developed. And this is something I've really enjoyed about our research methods. Some of these things we're not even involved in. They just seem to happen. It's very organic. So one of the homes actually took our logo, and I think they spent about 3 months with residents making this dignity blanket. And residents colored the hands by themselves. It took them about 2 months to color these hands. But the rec therapist who was leading this, she said it was interesting just to hear the conversations as people were coloring in the hands. So in a sense, it was an opportunity for them to kind of acknowledge death and dying in a very kind of non-pressured way. And it's a way to kind of acknowledge residents who die from the homes. We put this over the bed as we take them out, and some of the homes are doing honor guards as well. Incredibly powerful. So lots of cool things. But I did want to end with the dignity blanket because it's probably my most favorite part of this whole study, and I just think it's really cool. We are looking at rolling it out. We were just talking with George Heckman actually before this presentation, rolling it out in some homes here in the Waterloo region as well. With an ACP intervention. So, great. Thank you.
You talked about surveys, like satisfaction. Do you have a discharge, like after death, post?
That's a really good question. The homes we worked with, I don't think they do. So the survey that we sent out was a bereaved family survey, and response rates weren't that good. Sure, yeah. I don't know, do any of your homes send out a bereaved family member survey out? If you do, I'd be interested to look at that if you'd be willing to share it. Maybe you could email it to me.
We do, we just want to improve on it.
Yeah, yeah. So the other element to this that I didn't really mention was our post-bereavement phone calls. So that's something we're trying to kind of just check in with people to see how they're doing. So I think the survey in some ways, I think, is less intimidating.